My name is Cheryl Fatibene. I'm the Chief Nurse Practitioner Officer at the NNCC, and on behalf of the National Nurse-Led Care Consortium and the AANP, I would like to welcome you to today's Lunch and Learn webinar, Chronic Care Model for Hypertension Control. I will be moderating our discussion today, and I thank you for taking your valuable time to join us. Our presenter is Gordon Mattimoe, who has recently earned his DNP, and this is his capstone project. Today's webinar is being recorded and will be available in the upcoming week on our NPSAN portal page, and a link to the recording will be sent to all registrants. Participants will be muted throughout the presentation. I encourage you to submit questions during the presentation. Please use the Questions tab on your GoToWebinar control panel as seen here to ask your question. It will be relayed to the presenters and answered at the end of the webinar. A survey will pop up at the end of the webinar and will be sent in an email later today. Please take a few minutes to complete the survey evaluating this activity. Please take a moment to evaluate this activity as your feedback is critical to the ongoing development and presentation of our webinars. The slides for today's webinar are available as a handout, which you can access via the Handouts pane on your control panel. You can click the name of the handout and it will be downloaded via the default web browser. Before we get started with today's webinar, I'd like to introduce you to our presenter, Gordon Mattimoe. Gordon Mattimoe has 22 years of nursing experience and is currently working as a family nurse practitioner at the Andrews County Health Department. He has been employed by ACHD since August of 2012. He coordinates the immunization program there and is the founding member of Andrews Community Immunization Coalition. Gordon recently earned his DNP and is adjunct faculty at the University of Texas. Gordon served as an LVN medical specialist in the U.S. Army and participated in multiple assignments, including deployments to Desert Storm, Desert Shield, and Provide Comfort. Let me take a quick moment to talk to you about the national investment taking place for quality improvement in the U.S. with the help of our federal government and the organizations who are presenting this content as part of Transforming Clinical Practice Initiative. The Transforming Clinical Practice Initiative, or TCPi, is CMS's largest ever investment in practice transformation with an investment of greater than $700 million over 4 years and an enrollment of 150,000 plus providers across the country. The NNCC, or National Nurse-Led Care Consortium, is a membership organization with over 250 nurse-led practices on its membership roster. Our mission is to advance nurse-led care through policy and consultation and programs to reduce health disparities and meet people's primary care and wellness needs. Our partner in this initiative, the American Association of Nurse Practitioners, is the largest full-service national professional membership organization for NPs of all specialties. It is leading the way in advocacy, continuing education, and professional development for over 60,000 members. CMS funded the NNCC and the AANP to support enrollment of NPs into practice transformation networks, or PTNs, across the country, and to develop NP-specific educational material that facilitates practice transformation in advance of the upcoming payment reform changes with CMS. NNCC and the AANP are the only nurse-focused guarantee of the TCPi project. NNCC and AANP agree that this initiative is important to ensure NPs receive the support they need to remain competitive in a changing healthcare landscape. NPs are the future of primary care in the United States and already provide high quality and cost-effective care. This initiative is an opportunity for NPs to prove that by helping CMS and the broader community, healthcare community, build the evidence based on practice transformation for people. It's funding out of the goodness of their heart. They want to use the country for payment reform. In particular, reform under MACRA. Medicare Access and CHIP Reauthorization Act. Many of you have probably heard of MACRA. It's legislation that was passed to establish Medicare's quality payment program. It hasn't been finalized yet, but under this quality payment program, there are two payment adjustment mechanisms to incentivize quality tied to Medicare Part B payments. MIPS, or Merit-Based Incentive Plans, and an alternative. Clinicians will end up associated with MIPS, or the Merit-Based Incentive Plan. Details of all of this aren't as important as the general trend. MIPS and retirement. TCPi and their networks are meant with the skills necessary to execute these four elements. A large growing role in the delivery of health care, especially primary care. The NNCC and the AANP want to connect NPs to TCPi-funded practice transformation networks, or PTNs. These peer-based learning networks have the responsibility for enrolling and supporting clinicians. They provide free boots-on-the-ground technical assistance and services to help realize practice transformation. How can we as NPs help the PTNs to serve as leaders in their networks? NPs are more familiar with many aspects of the change package than are their physician counterparts. NPs have experience working in collaborative, interdisciplinary, team-based environments. PTNs can provide the NPs and nurse-led health centers with critical resources for practice involvement and access to larger networks of clinical peers. This pulls NPs and the smaller nurse-managed health centers out of isolation. I want to talk briefly about how these changes are made within a practice. The TCPi change package was designed using the driver diagram model from CMS I noted on this slide. These three drivers describe the changes that are needed to transform any clinical practice and meet the TCPi goals, as well as to facilitate important changes to the way that care is delivered and the business of healthcare is kept viable and healthy, especially for nurse practitioners. The drivers are broken down into primary and secondary groups. This presentation will address all three TCPi drivers: patient and family-centered care, continuous data-driven quality improvement, as well as the third driver, sustainable business operations. I would now like to introduce our presenter, Gordon Mattimoe, DNP, to talk about how using the chronic care model helped improve hypertension control for his patients in a rural health center in Texas. I will turn the presentation now over to Gordon.
Thank you, Cheryl. Can everybody hear me?
We can hear you great, Gordon.
Okay, so acknowledgements. This was part of my DNP program. I spent 2 years with this. Dr. Susan McBride was my capstone advisor and is a brilliant lady. And Dr. Deb McCullough is my boss and was very good along the way and really supported the project. And Richard Gilder did most of my data analysis for me and was a great help as well. Next slide. So everybody knows the significance of hypertension. I won't go into this too much, but the cost of uncontrolled hypertension is immense and really contributes to heart disease and disability as well as death. Of course, you know, the sequelae after stroke can be much worse than actual death. Next slide. So the way this project came about is when ONC announced a Million Hearts Challenge, and I took a long, good, hard look at that and really it was about clinical decision support, improving care for with using the Million Hearts ABCDS or the aspirin, controlling blood pressure, managing cholesterol, and smoking cessation. That's really where this started, and then it just focused on hypertension. Our clinic, we're in a rural area. The town's population is about 15,000. Our health department is small. We have 8 full-time FTEs and a couple of part-time folks. We don't have a dedicated IT staff. So anything that we did in the electronic health record was done by myself or our clinic director, who's our EHR administrator, Dr. McCullough. So there were challenges getting things done. You know, not only do we have our primary care practice where we see uninsured, working poor, anywhere from 0% of federal poverty to 100% of federal poverty. We also see county employees, most which are insured. So looking at the chronic care model, I saw an opportunity to improve care utilizing the CDS within the EHR, and discovered something called a care coordination medical record within the EHR, which wasn't being used. Then of course we used for the hypertension control, we used the Joint National Committee 8 guidelines to build the different CDS functions in the EHR. Next slide. This is just a snapshot of our patient population. 29.5% with hypertension, 25.2% with hyperlipidemia, 19.5% use tobacco, whether it be smokeless tobacco or smoking, and 17.4% have diabetes. Of course, most people being on the line, being providers, understand that most of those diabetics fall into that hypertension, hyperlipidemia category. So lots of chronic illness. Next slide. And then the benefits of controlling hypertension. This doesn't include controlling cholesterol, smoking cessation. I mean, just controlling blood pressure by 12 to 13 millimeters of mercury has huge benefits. 37% decrease in stroke, 21% decrease in CAD, 25% less deaths from cardiovascular disease, and 13% less deaths from all causes. Next slide. So one thing that came up as we went through this project as well is we had a HEDIS dashboard, which we weren't utilizing. So the HEDIS dashboard is the Healthcare Effectiveness Data Information Set. HEDIS is a tool used by more than 90% of America's healthcare plans to measure performance on important decisions of care and services. Altogether, HEDIS consists of 81 measures across 5 domains of care. Because so many plans collect HEDIS data, the measures are so specifically defined, HEDIS makes it possible to compare performance of health plans on an apples-to-apples basis. This is the current NQF, or National Quality Forum, controlling hypertension measure. This is the measure I started out with was a little different from this. Next slide. I'll show you that measure. Very important when you're building these things in the EHR, you have to understand numerators, denominators, and exclusion criteria when you're setting things up for the HEDIS dashboard. So this was the measure I started with. It just took into account patients 18 to 85 years old. It didn't take into account the JNC 8 guideline. If we go back to the other slide, where adults 60 to 85 were permitted to have the higher blood pressure, 150 over 90. So this is going to make our numbers look better when we're not going with that dashboard. Very important on those dashboards, when you're looking at your numbers, you have to be aware of where the data is coming from. And a lot of that data needs to be linked so it makes it to the dashboard. So linking data using a link code or logical observation identifiers names the codes so they attach to the actual HEDIS measure, and you're collecting appropriate data. Now, this is going to vary whether you're getting interfaces from labs, whether you're doing in-house labs. You have to make sure you link the codes to the specific areas, like we do an in-house cholesterol and we do an in-house hemoglobin A1C. We do some outpatient, so we have to make sure we link those hemoglobin A1Cs and cholesterols appropriately, so we're not getting dinged on the HEDIS dashboard. And it's real important that things get linked and it's being reported accurately, because by 2019 we're getting to that value-based purchasing where we're going to get paid for performance. Next slide. Next slide, please. Next slide, please.
Gordon, can you tell us which slide we're supposed to be on?
The eHealth Enhanced Chronic Care Model.
Please let us know if you can see that.
I cannot. There we go. So the eHealth Enhanced Chronic Care Model was a derivative theory of the chronic care model. With advances in technology, it was possible to enhance the CCM. Self-management support is available in many forms from the electronic health record, by reminders, alerts, and using that HEDIS dashboard, we can also pre-plan for patient visits. I can run a report for upcoming visits and pull up my non-compliant patients so we can plan interventions at that visit. The CDS functions assist providers in clinical decision-making. Patient portals offer patients access to all kinds of information and communication with providers, as well as educational materials. We also have a smartphone app called Helo, which patients can just download an app from the App Store, which provides them with real-time medication lists, immunization records. They can get their lab results, so it helps coordinate care as well if they're going to other providers. So healthcare delivery is changing with ACOs, primary medical care homes. Reporting features in the EHR are making it possible for practices to participate in these programs. You know, the HEDIS dashboard is a good example of that. The basic chronic care model exists within this. It's just a derived theory. It's just been updated to work with the current environment. Next slide. So clinical decision support from healthit.gov. Clinical decision support provides clinicians, staff, patients, or other individuals with knowledge and person-specific information intelligently filtered or presented at appropriate times, to enhance health and health care. CDS encompasses a variety of tools to enhance decision-making in the clinical workflow. These tools include computerized alerts, reminders to care providers and patients, clinical guidelines, condition-specific order sets, focused patient data, reports and summaries, documentation templates, diagnostic support, and contextually relevant reference information, among other tools. You really have to look at what your record has to offer. There's plenty of diagnostic support. Big thing when implementing anything new is that clinical workflow. It needs to be mapped. Multidisciplinary team needs to sit down and walk through the workflow, do a PDSA cycle, plan, study, act, and get that process flowing before you go live. Order sets. We built a hypertension order set straight off of the joint JNC8 guidelines. Has all the JNC8 recommended antihypertensives. So it's very easy and quick to select those medications. Also on the order sets for such as annual eye exam, there's a spot to order it. Not only that, it shows when the patient had the last referral for eye exams. So we're getting them their eye exams annually. Patient education can be published to the portal directly off the order set, and it can also be printed if the patient is not enrolled on the portal. Even with our underserved population, we find that folks have smartphones and they use smartphones. They may not have unlimited data, but they can, we find, go sit outside the library with the free Wi-Fi and can do things on their phone. So they're using smartphones, and they can be great tools for them in managing their own diseases. Documentation templates. You can have one for any chronic disease. It's just a matter of building them. Great feature in our record is our alerts. On our alerts for diagnosis code, you automatically, for diabetes for instance, it will automatically come up eye exam, hemoglobin A1C, the last one, whether they're due, microalbumin, when the last one was, when they're due, foot exam. It's all right there at one click. It just makes life a lot easier. And again, use those guidelines to develop those order sets. Next slide. So really, what you have to take into account with clinical decision support is what information do you want? What intervention type do you want to do, or the how? Who the recipient is. Is it the provider? Is it the patient? Is it the nurse? Is it the MA? Where the information is delivered and how it's delivered. Is it the patient portal? Is it to the provider on their screen? And when do you want it in the workflow? Again, real important to map those processes while developing this. Next slide. So you want evidence-based, suitable guideline action pertinent to the circumstance. And again, building those order sets and the alerts have a lot to do with that. Considering all the care team and members, including clinicians, patients, and their caretakers. CDS intervention format based on intervention types described in the sections such as alerts, order sets, documentation tools, data display, or reference information. The right channel refers to the display of information, where the information is being displayed, and you want it in the right point of the workflow. Next slide. Doing a literature review, it's definitely apparent that you can control chronic disease optimally using clinical decision support. It's not just that, it's the patient engagement. And the electronic health record offers numerous ways to encourage that patient to be involved in their care. Of course, if we can decrease hypertension, we can decrease comorbidities and mortality. And you can assess that impact through the reporting features within the electronic health record with registries and reports. Next slide. So the top red squares are the chronic care model indicators: linkage to community, support for patient self-management, coordinated delivery system and design, clinical decision support, and clinical information system. And the blue represents how or what we did within the EHR. Actually, we even built a lot of things into our websites for patient education, our website for patient education. So data registries are big importance in getting patients plugged into different programs, especially smoking cessation. In the state of Texas, they have a pretty robust smoking cessation program we can use. Patient empowerment. We use this care coordinated medical record. So when patients are identified as having chronic illness, most of them it's multiple, the provider enrolls them within the CCMR. Then those patients come back to do a visit with one of the nursing staff, and they go through a health risk assessment, which has been built based on their chronic illness. And they go through a motivational interview where they try and identify any barriers to care. Not only the patient is invited to that initial CCMR visit, but patient families, spouses, caregivers. We also do a lifestyle assessment, and again, education provided for smoking cessation, anything like that. But best of all, the patients do goal setting. And then again here with our HELO application, patients can actually report blood pressures through the HELO application. They can report blood sugars, and we can also, they're also updating it so they can put in their daily activity, so as far as exercise and things goes. And for coronary care with all providers, BHR, we can electronically send records directly to other providers, encrypted email. And then clinical decision support, incorporating the evidence, again using order sets, alerts, and registries. And then clinical information systems. The registries and the reports, we can do campaigns, like we're getting ready to start our flu campaign, where the electronic health record actually, it'll send out text message, it'll send out emails or phone calls depending on the patient's preference. So it's a good way to get those patients engaged. Next slide. Along the way, I stumbled into this chronic care management service, the CMS, the CPT code 99490. You can practices can charge for, it must be 20 minutes, at least 20 minutes of clinical staff time directed by a physician or other qualified healthcare professional per calendar month, with the following requirements. The patients have to have 2 or more chronic conditions, expected to last at least 12 months or until the death of the patient. Chronic conditions place the patient at significant risk of death, acute exacerbation, decompensation, or functional decline. And comprehensive care plan established, implemented, revised, or monitored. Again, our CCMR record, we can actually bill off of that because it is recorded. But not only do they come in and do the initial assessment, but there's phone call follow-up where they'll follow up about medications, they'll follow up about activity, they'll follow up about blood pressures at home. So all that can get filled out, and that's a $45 a month for indirect care. We don't have a lot of Medicare. We're not going to make money off of that, but it is a little income. Next slide. So to measure the outcomes, the clinic used control charts to monitor blood pressure control. We actually used a P chart. Best fits the data because the sample size was non-conforming. The P charts we run has still not shown any patterns of special cause variation. They continue to run smoothly. And we did several logistical regressions and ran numerous statistics, and really the only thing we found of any statistical is running a Mattimoe test on sequential visits to the clinic. All hypertensive or all were hypertensive. We ran it against males against females, and of course females made their visits under the male population. The males with the most serial visits had better hypertension control, which really shows us that those patients that were engaged had better control of their chronic illness. Next slide. So what we were able to do is establish a system to monitor success over time and executed the program components to track, trend, and improve the care of hypertensive patients. The chronic care model is a flexible framework easily adapted to the clinical environment, and the eHealth CCM worked well to guide the EHR optimization to improve hypertensive outcomes. Next slide. So implications for practice: designing strategies to optimize the EMR to improve patient outcomes, patient-centered outcomes, lifestyle modifications improve chronic disease, and engaged patients do better. And next slide is my references. And Cheryl?
Yes, we're here. So
okay.
at this point, I'd like to open it up to the group and see if anyone has any questions at this point about any of the contents of Gordon's presentation. You can type them into the chat box on your screen, and we'll give you a moment or two to do that to see if there are any questions from the group, any feedback. So it looks like someone's asking about whether or not the slides would be sent out. Yes, they will. Yes, they will be sent out. And they're available actually to you right now. If you look at the box, there's a handout section, and you can download them yourself right from the presentation. So why don't you try that and see if that works.
It looks like we've got a question from Kathleen Porcelon, and she's asking, she has a question for you, Gordon. She's asking, was the CCM model easy to apply to hypertension? What was your experience with that?
It was very easy to apply. And actually the eHealth model, if you look at it, is really makes it, it's not just hypertension control it applies to, it's utilizing the EHR and all the different bells and whistles we have now to get that patient engaged and control the hypertension. You know, just a simple smartphone application. Patients really use it, enjoy it, and it gets them engaged.
Another question for you, Gordon, from the group is about the EHR. Can you talk a little bit about the system that you're using and why it was particularly well suited for this, for your use in this case with collecting information on patients?
Well, we use eClinicalWorks. It's eClinicalWorks is the only record I've used. I've found it easy to work with. The registries and the things you can pull out of it, if you're building things in structured data, are very useful. The HEDIS dashboard can do so much. It can tell us so much about our patient population. There's even a function in our HEDIS dashboard where we can geomap different chronic disease throughout the community. We only have one zip code, so it's not, that geomapping feature isn't so useful to us, but for larger communities it would be wonderful. You know, envirogenics, folks that live close to airports have a problem with hypertension. People that live close to freeways have a problem with hypertension. You know, if you can map those things out, I think it tells providers a lot.
Another question that we have here on the back end, Gordon, is how many patients were enrolled in your study?
We took every patient that had a diagnosis of hypertension. From October 1 of, let me see, it would have been, it was October 1 of 14, so I would have to go into the back end and see actually how many patients, but it wasn't just patients, it was everybody who came for a visit. It was all sequential visit for hypertension. Controlled yes or controlled no was the way we ran the numbers.
So about how many, what was your N on your study? How many were there?
I would have to pull the sheet, so I'm not lying to you.
Okay.
But it was over 600 sequential visits.
Oh, wow.
And what was the length of the study? During what period of time did you collect data? For how long?
October 1 to March 30.
So about 6 months?
Yes, ma'am.
Okay. And I have just a question for transferability of this information. I wonder if there's anyone out there that has either used the chronic care model or another type of model for patient tracking and outcomes that they'd like to share, and you can chat in. And I'll read you a question, Gordon. There's a question that says, you mentioned that your patients using apps on their smartphones. Which health applications are your patients using on their smartphones that are most useful for self-management of chronic conditions?
You know, there are a lot of free exercise applications that won't interface with the EHR, but patients can bring that data into you so you can see what kind of activity they're doing. You know, they have dozens of those free programs. We actually, in our Hilo application, will actually connect glucometers to the EHR, and that actually flows from their smartphone to the Hilo app. We can actually see that in the record. We can do blood pressures from a smartphone, glucometer, heart rate, etc.
Hi, this is Tiffany again. So we have more of a comment from one of our audience members, Kelly Baez. I hope I'm pronouncing your last name correctly. And she's telling us that she's experienced using the chronic care model to track outcomes of diabetes. And Kelly, if with your permission, I would love to unmute you if you'd be willing to share with the audience your experience with using the CCM model. Just go ahead and raise your hand if that's an okay thing to do. Okay, well, we might have lost Kelly. Gordon, do you know if the CCM model has been used to track other chronic diseases like diabetes?
Yes, there's lots of literature using the CCM. Just takes a little Google Scholar search. You will find a lot of literature. A lot of it focuses on diabetes, but other chronic illness as well. And the literature is pretty good overall as far as the CCM goes in managing chronic illness. But again, I think it takes it back to engaging that patient, and that's really what the chronic care model, the soul of it is.
And so we're still taking questions if anyone else wants to chat in questions. And we were looking for Kelly, if she's still on the line.
She can raise her hand.
If you can raise your hand for us to talk a little bit about the chronic care model that you've used in practice. Kelly, are you still with us?
Okay.
Yeah, we don't see Kelly on the line. She may have.
There she is.
Oh wait, there she is. Okay, we're unmuting you, Kelly.
Okay.
Why don't you go ahead?
Hi, can you hear me?
Yes, thank you.
Okay. My name is Kelly Valles, and I also just completed my DNP project on the chronic care model. We had good outcomes in our clinic where we managed patients who had both serious mental illness and diabetes. So I wanted to find out why we had good outcomes. So I created a tool based on a few other tools to do chart reviews to see what aspects of care were related to diabetes outcomes of hemoglobin A1C. And what I found was that the number of provider visits went up with worse hemoglobin A1C, and also the higher percentage of time over the year that we set patient-specific goals with the patient at the end of the visit, that also correlated to a higher hemoglobin A1C. So overall, I concluded that we gave more intense care when patients were doing worse with their diabetes, but I kind of mapped the different chronic care model components and actions in our clinic related to each component, and then looked at charts.
Awesome. Thank you so much, Kelly. I really appreciate it. I find it fascinating to be able to hear the application of this model across a number of chronic diseases. So thank you for that. I have a question for the larger audience. Well, Gordon, actually, if you could maybe start us off. What was your experience working with the staff and the implementation of such a robust quality improvement program? We've been hearing some feedback from provider practices that we're working with that, given that it's such a large component and an integral component of the Transforming Clinical Practice Initiative, and it's such an integral component in readying practices for payment reform, oftentimes they feel unprepared. So can you speak a little bit to your experience at the site that you worked at?
Everybody from the front office staff to the nursing staff, our physician, we're really a nurse-led clinic. Our physician is here 2 days a month. Everybody is involved in our quality assurance program, and this was a quality assurance project. They're excited about it. They enjoy getting involved at it. They like to see the numbers. They like to see the numbers go in the right direction. They don't like to see the numbers go in the wrong direction. So they're eager to participate and really actively participate in the quality assurance program.
Thank you, Gordon, for sharing that. We have another question from Rosemary Wyatt. Given that there's so many factors affecting blood pressure other than the exclusions list, how reliable was your results? And did you examine the impact of other possible factors, for instance, obesity?
Obesity was one of the things on the data collection. We found no correlation on our logistical regression.
Okay, great. Thank you for that. I hope that answered Rosemary's question. We have another question as well from Huyang Park, and I'd like to ask you how you could embed the CDS in an EMR. Are the contents in CDS standardized so that they can be reimbursed within your current healthcare system? How did you build a comprehensive care plan?
The comprehensive care, you just use that CPT code, and as far as providing the care, you have to document it. Of course, you don't want Medicare to come do an audit and not have any documentation of the 20 minutes of care a month, so you need to have it documented. We frequently use our telephone order or telephone encounter to document that process, so there is a trail if there is an audit. Like I said, we don't have a huge Medicare population and don't bill much on it, but we do document using that telephone encounter feature. Did that answer the question?
We'll wait for her to chat in.
I believe this question is from Grace. Grace, if you can raise your hand, I can go ahead and unmute you. Maybe you could explain your question further. If you can just raise your hand. Unmuted right now. Grace.
Hello?
Yes, your line is unmuted. Go ahead.
Oh, so can you hear me?
Yes, you're unmuted.
Okay.
Thanks.
When I see your model, I see really this is really interesting, and really I wanna see this type of development program. But my main question is this: when you develop this type of the comprehensive care plan, how could you put this information to EMR? Because most time the different hospital or clinical situation use different EMR. So did you develop the program by yourself, or even you said you don't have enough IT guys? So I wonder how could you make your program, the comprehensive care plan in your EMR system?
That care plan was a module that we didn't have activated. It was something available that we weren't using. I don't even think we were aware we had it. But
so all the information that you provided is not actually using this EMR system, just you focus on only content-wise?
can you repeat that, Grace? I'm sorry.
Okay. So I understood, you developed some, some type of different EMR system, so they can include the comprehensive plan that you develop, so they can be recorded in the computer system. But you sound like you didn't reach that place. Just you test the effect of your comprehensive care plan only, not in the EMR system, right?
The CCMR is a module within the EHR. The goal of the project was to maximize the utilization of the EHR in the CDS.
All right. Well, maybe, Grace, if you have any additional questions, we can connect you to Gordon offline, just so we can kind of move along a little bit. So, Gordon, we do have another question from Megan Speakermeyer. She is asking for you to explain the process and the costs of joining the HELO network.
Again, it was a module within the system that wasn't being used. Patient portal is part of the EHR, and part of the portal was the HELO application. There was no additional cost.
it looks like there's no additional questions at this time. I did want to thank Gordon for taking the time to do with us today and for his work doing this capstone project. And just to pull all this back to kind of where we started from in talking about practice transformation. So to really kind of just boil it down to what's important, if we think back to TCPi and the drivers around patient and family-centered care, which clearly this is a rural clinic, you know, in a small community, and this really had a tremendous, you know, this was focused on the individual patients. You know, the second driver of continuous quality data-driven improvement was really the ingenuity of, as you said, Gordon, the nursing staff, and pulling together using the chronic care model and then also a measure system to be able to flag you so that when certain patients would come in, you would have a better sense of their compliance. So you really used what you had. You were not given this program. It was something that you developed internally because you were looking for resources, and you looked and you found them. So I really give you credit for that. And then in the end, you know, when you center on patients and their families and you provide good quality care, and the quality care in this situation was seeing improvements and reductions in hypertension, you know, that goes a long way to the sustainability of the practice in that you maintain your patient, you know, load. Those patients will likely let other patients know of the good care that they have received. You get a good reputation for using evidence-based, you know, measures, and it all brings it back to what we had started the program with, was talking about, you know, why this change package from CMS is really relevant to the day-to-day. So I hope that the NT community listening today sees and understands that, and that really was our goal, was to bring you, with this Lunch and Learn, something that was relevant to your practices, and to see how we as providers can really be leaders in that change. So just to end it, I just wanted to let people know of our next Lunch and Learn, which will be next month on October the 12th. And I had mentioned MACRA earlier on in this presentation. This will be a program dedicated only to MACRA, to talk about what that is and why it's important. Although it will be geared more towards the psychiatric and Peds, it's a good 101 on MACRA if you don't really know much about that. And then also, for those of you listening today, just so you know that we here at the NNCC will be having our conferences coming up on November the 12th. There'll be a train the trainer opportunity for those that are coming in to talk a little bit more about care team formations, and we will have a workshop that we will be doing that day. So if you have an interest, please go to our website and sign up today. And again, this all ties back into that practice transformation. And if you have any additional questions on either the content of today's presentation, or if you have more questions about TCPi and what's going on for us as nurse practitioners across the country right now with change management, please reach out to Stephanie Depew, who's helped co-host this Lunch and Learn with me today, and her information is there for everyone. You can contact her by phone or by email. And I thank you, everyone, for joining us today, and I wish everybody a good afternoon. And thank you again, Gordon, for making this happen.
You're welcome. And if you can give my email address to Grace, I'll be glad to.
Oh, we can go ahead and provide that to Grace directly, Gordon.
Thank you.
All right, thank you. Have a good afternoon, everyone.